to avail a 10% off in your plus courses. Apart from that, for our viewers, those who are coming through a Facebook or the other social media platform, they can use the code that is pharma10. This pharma10 is the code, is can be used to unlock the free courses. Pharma10 is the code, right? So without making any further delay, let's get started with the today's session. The very first question that I am having, please read the question carefully, where I'll be giving you the options. A manic patient was on long-term diuretic therapy, now presents with polyuria and polydipsia. Possible cause of this polyuria and polydipsia is, okay, so there are 4 options before your screen, and I'm sure all of you guys have already thought of that why is there polyuria and polydipsia, what could be the possible symptom. I'm giving you 30 seconds for this. Let us see how many of you guys can get this easily. So there is neurogenic diabetes insipidus, nephrogenic diabetes insipidus, okay, lithium mediated excessive solute reabsorption, okay, psychogenic diabetes insipidus. Okay, let us see how many of you can get this easily. Okay, so less than 50% of you have thoda lag ho raha hai. Okay, any other student, those who are feeling there is a lag? Okay, 45% of you have got this correctly. These are the students in our leaderboard. Very good evening, everyone. Any other student, those who are feeling that there is a lag, I can fix it out if there is a lag. Hi guys. लैग हो रहा है क्या? और किसी को लैग का प्रॉब्लम आ रहा है, लैगिंग आ रहा है? ओके, जस्ट गिव मी अ मिनट, I'll just fix it out. Just give me a minute. Top, that means there is a decreased amount of ADH. Okay, decreased amount of ADH from the central nervous system itself. Okay, so nephrogenic and neurogenic diabetes insipidus is one of the very favorite examiner question for the examiner. Okay, let me give me some time to just simplify it out and discuss why it is not nephrogenic. Lithium induced diabetes insipidus, guys, it is always and always nephrogenic in nature. Whenever there is a lithium induced diabetes insipidus, let us see how it happens. And before we understand this, okay, yes, Subhesh, this is one of the MCQ based series, right? This is one of the MCQ based question, but definitely discussion will be helping everyone. Okay, now let us see what happens in the normal population, and then accordingly we will try to understand in the central diabetes insipidus or the nephrogenic diabetes insipidus. What I have drawn here is one of the segment of the collecting duct. Please pay attention to this one. What I have drawn here is one of the segment of the collecting duct. Okay, and in this collecting duct, what we have here is, let us say this is the V2 receptor that is present over the collecting duct. This V2, that is vasopressin receptor, whenever ADH or the vasopressin that we are having, ADH or vasopressin, that is the same thing, that is coming from the central nervous system. ADH or vasopressin that is coming, that is released from the central nervous system, they will be acting over V2 receptor, and they will be causing upregulation of the aquaporine, right? This aquaporine are the pure water channel, and they will be causing your reabsorption of the water. So whenever there is a decrement, whenever there is a decreased amount of fluid inside our body, what will happen at the at this particular time when the fluid level is lesser in our body, ADH or vasopressin will be released from the body, from the posterior pituitary, right? And this will be acting on the V2 receptor, and they will try to conserve the water. They will try to save the water through the aquaporine channel. I hope it is clear to all of you. This is how the body tries to save the water. But in a patient with the diabetes insipidus, what happens? Let us say that there is central diabetes insipidus, CDI, central diabetes insipidus, and other one that we are having is the NDI, that is nephrogenic diabetes insipidus. This is the first question, Dr. Amrita. There is a central diabetes insipidus. In this central diabetes insipidus, remember, the ADH from the brain is not coming. There is a decreased or there is no ADH that is coming from the brain, right? That is from the posterior pituitary. Therefore, in response to this one, please let me know what will happen to the V2 receptor. Whatever V2 receptor that is present here, what will happen to this V2 receptor? None of these V2 receptor will be stimulated, right? And if the V2 receptor is not stimulated, what will happen, guys? Just think it out and let me know. All the fluid that is present here, they will be lost in the urine, right? All the fluid will be lost in the urine, and therefore the patient will be presenting to you with the symptoms like your polyuria, more polyuria, and the patient will also be having symptoms like your polydipsia. right? The urine pH that we are having, urine will be hypoosmolar. Urine will be your hypoosmolar. Okay, more fluid is coming, definitely you can understand hypoosmolar urine, right? Diluted urine. But the body में क्या होगा, concentration inside the body will be high, right? Because none of the fluid is reabsorbed. So aquaporine question mark, right? ADH is also question mark, right? That means ADH is not coming from the brain. Posterior pituitary. What happens in the nephrogenic diabetes insipidus, please pay attention that in the nephrogenic diabetes insipidus, this is the receptor, that is V2 receptor, and compare this V2 receptor that I have drawn earlier, right? There is a resistance of the V2 receptor. This V2 receptor itself is, right, not working. There is enough amount of ADH that is coming from the brain. Brain is giving enough or normal amount of ADH. Vasopressin is normally coming, right? Or ADH, antidiuretic. The name itself is antidiuretic. So, right, ample amount of antidiuretic is coming from the posterior pituitary, but this receptor itself is resistant. I'm sure you guys can make a very good distinction here. That once again the patient symptom will be same: polyuria, polydipsia, because whatever water that is present here, definitely it will be lost in the urine. None of the aquaporine will be right upregulated, or aquaporine opening nahi hoga. There will be no opening of aquaporine. Therefore, once again the urine will be hypoosmolar, and body mein kya hoga? Body mein there will be hyperosmolarity inside the body. Okay. Now quickly let us summarize it out. The treatment for this one. If there is a no ADH, can we give a synthetic ADH? Yes or no? Can we give a synthetic antidiuretic hormone? Yes. A synthetic ADH that we can give, that will be your desmopressin, right? 2019, right? Board exam question, right? Desmopressin can be given. That happens to be one of the synthetic ADH. This desmopressin will be acting on this V2 receptor. Once it is going to act on the V2 receptor, they will be causing your opening on upregulation of the aquaporine, and they will now cause reabsorption of the water. Clear? They will be causing reabsorption of the water. So therefore, remember, desmopressin that we are having, that is your synthetic vasopressin, can be used. Now my question to you is that, can I also use desmopressin in the nephrogenic diabetes insipidus? Can you guys tell me, can I also use this, right, desmopressin? Use करें? नहीं करेंगे. Why? Because there is ample, right, normal amount of ADH is there. Normal amount of ADH is coming, so हम use नहीं करेंगे, right? I hope it is clear to all of you. Therefore, that for the treatment of this one, right, for the treatment of this one, the drug of choice that we use usually for the treatment of this one, this is the drug of choice. Desmopressin is the drug of choice, right? Here we can use thiazide diuretics. Very good, right? And among the thiazide diuretics, we will be preferring chlorthalidone, or any of the thiazide diuretics can be used here. Okay, thiazide diuretics is the one that will be preferred. Now thiazide diuretic is acting via multiple ways. One of the ways of the thiazide diuretics here, one of the ways that we are having, multiple hypotheses has been given how it is working. One of the ways is that these thiazide diuretics, whenever we are going to give thiazide diuretics, they causes your aquaporine generate, right? CAMP mediated aquaporine generation. They causes your more and more CAMP mediated your aquaporine generation, right? This aquaporine will now be causing your reabsorption of the water. One of the very simplest explanation you should understand and remember, that CAMP mediated aquaporine generation will be there with the help of your thiazide diuretics. Okay. However, other hypothesis has also been given, but this is the important that you should know. Okay. So aquaporine will be generated through the thiazide diuretics. So in the nephrogenic diabetes insipidus, yes, we can use this. Now, how is it different from others? How is it different from other condition that is also present in the at the level of the collecting duct? Let me give you another scenario here. A patient that is coming to you, हाँ उसी की बात कर रहे हैं डॉक्टर Aziz. Just give me some minute, I will talk about interaction as well. Just give me 2 minutes of time. Definitely I will talk about interaction as well, because anything that is important, as I have told you, I will be talking about it. Okay. Now there is another scenario here that is known as your SIADH. Look at the name. Look at the name. The name itself is saying SIADH. That means there is excessive ADH, syndrome of inappropriate ADH secretion. Boys and girls, the name itself is SIADH. That means it is a syndrome of inappropriate ADH. बहुत सारा ADH आ रहा है from the posterior pituitary, right? All the ADH from the posterior pituitary, excess of ADH is coming, and all this ADH is going to act over the collecting duct V2 receptor, right? The V2 receptor that is present. It is very easy for you to understand that whenever they are going to act on the V2 receptor, definitely they will be causing more and more generation of the aquaporine, and more generation and upregulation of aquaporine will be causing your more and more reabsorption of water. In a condition like your SiADH, what will be the condition of the urine, guys? What will be the condition of the urine? There will be concentrated urine, right? Or hyperosmolality of the urine. Hyperosmolality of the urine, right? What, right? There will be dilutional hyponatremia inside the body. This is the body, right? Dilutional hyponatremia. Body में dilutional hyponatremia होगा, right? But the urine will be highly concentrated, and the examiner has already asked this question. They have given the scenario and they have said that this is the serum sodium level. That means there is they will show you reduced serum sodium level, dilutional hyponatremia. What could be the possible cause, or what would be the possible use? Okay, so every time that you see, every time this ADH is coming and they are acting at the V2 receptor, there will be upregulation of this aquaporine. This aquaporine is causing generation of the reabsorption of the water. Why not block these ADH receptors? V2 receptor. Why not block this V2 receptor, that is one of the ADH receptor? Yes. So definitely, as their management, you can use V2 receptor blocker. You can use V2 receptor blocker. Very good. That is your, right, vaptans. We call them as a vaptans. That is your, right, conivaptan, conivaptan, tolvaptan. This conivaptan and tolvaptan, guys, they are going to act on which, right? What they will do? They will simply block this receptor, and after blocking this, they will have an intrinsic activity of 0. Please try to understand what I told you, that they will be blocking the receptor. They are the V2 receptor blocker having an intrinsic activity of 0. Intrinsic activity is 0. What do I mean by this? That means after blocking, they will not allow the ADH to bind here. Right, ADH cannot bind here, therefore there will be no aquaporine generation. Right, I hope it is very clear to all of you. Central diabetes insipidus, nephrogenic diabetes insipidus, right? And now I am discussing with you SiADH. This SiADH that we are having, conivaptan, tolvaptan, this can be used in multiple conditions. One is, it can be used as a drug of choice in a patient with the SiADH. Yes, agreed. It can also be used. Yes, Dr. Amrita, this is the drug of choice. This is the drug of choice. मैंने लिखा है ना यहाँ पे drug of choice. Okay. It can also be used in other condition, like for example your congestive heart failure में you can use, right, for the treatment of the hyponatremia as well. For the treatment of the hyponatremia. However, studies have also said that there is a decrease in the mortality that is due to ADPKD. Yes, in the polycystic kidney, right? Polycystic kidney disease may be also it can be used, right? Polycystic kidney disease may they are going to reduce this incidence of mortality in the polycystic kidney disease as well. Okay, so that is one that is one drug that we are discussing here, that is V2 receptor blocker. Okay, apart from that, one of you have raised a query about lithium plus, right, lithium plus thiazide diuretics, right? Lithium plus thiazide diuretics साथ मिलते तो क्या होता है, right? Try to understand a very important fact here, that whenever we give a thiazide diuretic, guys, whenever we give a thiazide diuretic, this will be causing your diuretic effect. They will be causing diuresis. I hope it is clear to all of you. Very simple. Thiazide diuretics, they will be acting at the DCT level and they will be blocking your NaCl co-transporter. इसमें कोई doubt तो नहीं है. Hashtag sign is for the blocking sign. कोई doubt नहीं है. They will be blocking NaCl and they will be causing diuresis. I hope it is clear. Now, once they cause diuresis, body will be suffering from loss of sodium and there will be hyponatremia. The body will be having hyponatremia. That means body will be, right, yes, body will be suffering from this loss of sodium, and in response to this there will be compensatory reabsorption. अब क्या करेगा ये PCT से compensatory, right, सोडियम का reabsorption करना शुरू करेगा through this epithelial sodium channel, and remember, this epithelial sodium channel is the same channel which is also utilized by lithium for the reabsorption. Right, so compensatory sodium reabsorption through the epithelial sodium channel along with, right, this is along with the lithium. That is why lithium toxicity can actually be increased with the thiazide diuretics. Okay, lithium toxicity thiazide के साथ इसीलिए बढ़ सकता है. ठीक है, so 2-3 important points that I have told you, that is very very important, and please believe me, these are all very conceptual and examiner is very fond of asking. Your examiners, those who are making your paper, they are very fond of asking this type of questions. Okay, I hope it is clear to all of you. एक बार रिवाइज जरूर करिएगा. Definitely things will be outlined for you. Okay, so lithium induced, as I have told you already, the lithium always and always causes your nephrogenic diabetes insipidus, right? And another thing that you should know, that the drug of choice in lithium induced diabetes insipidus, will be your amiloride. Why amiloride? What class of drug is amiloride, guys? So this happens to be one of the potassium sparing diuretic. It happens to be potassium sparing diuretic that is acting by the ENaC blocker at the DCT, right? Epithelial sodium channel blocker at the DCT mainly, right? Mainly at the DCT, epithelial sodium channel blocker. However, it can block other epithelial sodium channel as well. Okay, so remember this. So three type of diabetes insipidus I told you. Central diabetes insipidus, the drug of choice will be desmopressin, agreed. Nephrogenic diabetes insipidus, thiazide diuretics, drug of choice. Third that I told you is lithium induced diabetes insipidus, that is your epithelial sodium channel blocker, that is amiloride. I hope this much information is good enough for this question. Let us proceed to the next question. Okay, क्वेश्चन को ध्यान से पढ़िए. 55-year-old patient was on digoxin therapy for the frank symptom of heart failure. The condition is poorly controlled. Hence, the physician added a diuretic agent with it, which caused the development of the arrhythmia. Okay, so digoxin की बात कर रहे हैं. I think in my heart failure lecture I have already discussed a lot about digoxin yesterday, and all those students those who have attended that, you know that what is the action of digoxin, what are their uses, what are the indication, contraindication, what are the drugs that is increasing digoxin toxicity. Everything I have summarized yesterday, right? All the students, right? So the condition poorly controlled, hence diuretic agent is added, which cause development of the arrhythmia and require hospital admission. Okay, so अब क्या हुआ? पहले सब ठीक था, then they added a diuretic. Now because of the diuretic there is development of arrhythmia. That means diuretic is actually doing some interaction. That means diuretic is causing digoxin toxicity somewhere or the other, right? थोड़ा सा रुकिए डॉक्टर राज. which of the following diuretic could be possible cause of this increased toxicity? Which of the following could be the possible cause of increased toxicity? Okay, so I hope कि concept डॉक्टर राज ने कॉन्सेप्ट अपना लगा लिया है, राइट? अदर स्टूडेंट्स ऑल्सो कैन यूज द सेम कॉन्सेप्ट एंड मार्क दिस आंसर करेक्टली. ऑल 100% ऑफ यू प्लीज. एप्लेरेनॉन, amiloride, indapamide, triamterene. Which of the following could be the possible diuretic that is causing this increased risk of toxicity? All right, so 40% of you have got this correctly. For my viewers and learners that are coming through the Facebook or other social media, you can watch the whole the whole video at the app actually, and you can also enjoy this whole quiz like जो scenario है, आप उसको you can enjoy it if you're directly coming to the app, because I'm sure that while I'm choosing the answer here you are able to see the key as well. So if you want to have a quiz like experience, definitely you should attend the app. Okay, and at the app you can use the code that I have given here in the comment section, that is pharma10. Okay, so let's get it. बिल्कुल Dr. Shantan, you have also got, Raj you have also got, right? Definitely we are talking about the hypokalemia because digoxin, yesterday I have told you guys, कल मैंने ये आपको चीज़ बताई थी कि in a patient with the hypokalemia, right, whenever I told you that whenever there is a hypokalemia there is an increase in the risk of digoxin toxicity, because in hypokalemia digoxin binding with the sodium potassium ATPase increases. Okay, so digoxin toxicity is actually increased with the hypokalemia. I hope it is clear to all of you. Now any diuretic that is causing hypokalemia, be it a loop diuretic, yes, loop diuretic, right, be it thiazide diuretic, any diuretic that is causing your hypokalemia will be increasing the risk of the digoxin toxicity. Okay, however there are certain diuretics that does not cause hypokalemia, that is known as your potassium sparing diuretics. This potassium sparing diuretic, boys and girls, they will not be causing hypokalemia. They try to save the potassium. No, I will discuss in more detail how is it working actually, but as of now just remember the potassium sparing diuretic that we are having can be remembered by the mnemonic Sita with an E, right? Sita with an E, right? So that is your spironolactone, right? Spironolactone, eplerenone, right? Triamterene, right, and amiloride, triamterene and amiloride. Okay, amiloride के बारे में I have told you already. Okay, so this is your Sita. Very simple way to remember. These are all the potassium sparing diuretic. What is the other thing that you should know? That above two drug is spironolactone and eplerenone. They are mainly your aldosterone receptor antagonist. Okay, aldosterone receptor antagonist at the principal cell of the collecting duct. They are the aldosterone receptor antagonist. This triamterene and amiloride guys, right? They are the mainly epithelial sodium channel blocker. Okay. That is why I told you amiloride is actually considered as a amiloride. स्पेलिंग थोड़ा सा मिक्स हो गया था, मैं अलग से कर दे रहा हूँ इसको. amiloride. Okay, amiloride, it is considered as a, right, drug of choice in the lithium induced diabetes insipidus. Scorpion is asking, sir, how should we prepare for second prof exam pharma? देखो सेकेंड प्रॉप में हो तो अभी तो स्टार्ट करो, बुक पढ़ना शुरू करिए आप लोग, है ना. बाकी हाउ टू प्रैक्टिस द एमसीक्यूज, डेफिनेटली वी आर हियर, राइट. यू शुड हैव योर होल रेगुलर क्लास नोट्स. So for the regular class notes, you can watch the whole plus classes that you are having, right? Attend the whole 55 to 60 hours lecture, right? Make the notes, revise the same, do the MCQs. That is what I will tell you. Alright, so any drug that is causing hypokalemia will be increasing the risk of toxicity. Out of all the drugs, see, eplerenone is a drug from the potassium sparing, amiloride is also potassium. Indapamide, which class of drug is indapamide? Thiazide diuretic, है ना? It is one of the thiazide diuretics. So therefore, definitely they will be associated with your hypokalemia. I hope कि बहुत difficult नहीं था ना ये, है ना. So yesterday I have discussed this and today I have used right in the diuretic as well. Okay, so everything is correlated only. Let's go to the next question because we have many questions to do. And next question, very important question. A pregnant female was on antihypertensive therapy. She states, question को ध्यान से पढ़िए, each of this line, all of you. She states that she has been on antihypertensive therapy before pregnancy itself. That means she's a patient of the chronic hypertension, right? The history of there is a chronic hypertension. Okay, so pregnancy से पहले से ही she is taking an antihypertensive drug. BP is well controlled, but recently she presented with new symptoms like nightmares, vertigo, reduced concentration and sedation. Possible antihypertensive agent she is on, right? Antihypertensive agent she is on. Okay, so I hope all of you guys have already read the options clearly and you are ready to mark them very clearly. Once again, please go ahead. Verapamil, oxprenolol, alpha methyl-dopa, valsartan. Okay, all of you please try. All the students, those who are live right now, please try marking. Okay, so I can see here that some of the students are still not marking. For our viewers at the Facebook, you won't be able to mark here. If you want to play really this one, please use the link that has been given already on my Facebook page and you can join this quiz at the app. Okay, so half of you have actually got this correctly. 55% of the students have actually got this correctly done. Rest of the students somehow could not get this. Let me just simplify it as simple as possible. What we have here is hypertension in pregnancy. Very simple, right? Hypertension in pregnancy. Two important things that we are having. What is the drug of choice for hypertension in pregnancy, guys? The drug of choice for hypertension in pregnancy is labetalol. That happens to be one of the third generation beta blocker. It is the drug of choice. However, if there is a chronic hypertension, right, chronic hypertension or any hypertension not responsive to, right, any hypertension not responsive to labetalol, you can use the alpha methyl-dopa as well. Hypertension in pregnancy, malaria in pregnancy, somehow they usually ask, right? NEET PG, that is their favorite one. Okay, so let me just summarize antihypertensive in pregnancy, right? Two important things you needed to know. One is क्या देंगे, one is क्या नहीं देंगे. One is which of the following is the drug that can be used or the right safer in pregnancy. Which of the following is safe in pregnancy. Second thing that you must know that which of the following should be avoided in pregnancy. या तो avoid करिए और they should be contraindicated in pregnancy. ठीक है? Yes, Dr. Srikar, बिल्कुल, right? So it's you just have to choose. To my surprise or to your surprise, some of the students even they have marked valsartan as well. Although valsartan is one such drug that is contraindicated. So we will see. Let me simplify it down for you. Safer in pregnancy. What all drugs are safer in pregnancy? Right? Very simple for you. Remember with the very simple mnemonic, Lady Harding Medical College. Lady Harding Medical College is a medical college in Delhi that is very safer from the females. Just a way to remember, na? So safer in pregnancy. Which is safer for pregnancy? Lady Harding Medical College. Lady Harding Medical College stand for your labetalol. That happens to be the drug of choice for the hypertension in pregnancy, right? Your other drug that we are having like hydralazine, right? Labetalol, hydralazine, right? Alpha methyl-dopa, and other one that we are having the calcium channel blocker. Alpha methyl-dopa is a alpha 2 agonist. Other alpha 2 agonist that we are having is clonidine, that is also safer in pregnancy. Remember, alpha methyl-dopa and clonidine, they both are safer in pregnancy. Okay, calcium channel blocker will be used, but remember which calcium channel blocker? It is the DHPs, dihydropyridines, DHP, that is nifedipine, amlodipine, and also your calcium cardioselective beta blocker, cardioselective beta blocker. Non-selectives are contraindicated. Non-selectives you will not be giving. Cardio-selectives. Okay. So Lady Harding Medical College, I don't think it is very difficult for you to remember. है ना, Lady Harding तो safer है ना ladies के लिए. So safer in pregnancy, Lady Harding Medical College. But what is avoided? I'll tell you. Whenever there is a pregnancy, avoid DNB. Right. This is just a mnemonic, right? I have I have nothing against DNB, just a mnemonic. Okay. So avoid DNB in pregnancy. What are the avoid DNB that we are having, right? Remember, ACE inhibitors or ARBs. As a matter of fact, all the RAS inhibitor drugs, right? All the RAS inhibitor drugs are contraindicated in pregnancy, like Aliskiren, or Enalkiren. They are also contraindicated. Okay. D stand for any form of diuretics. जितने भी डायबिटिक हैं, they all have shown to have teratogenic side effect, right? Sodium nitroprusside. This question I always get from the student over my different social media platform. I'll be getting, sir nitroprusside देंगे नहीं देंगे, नहीं देंगे, है ना, contraindicated है. One of the agent, sodium nitroprusside, contraindicated. Okay. B stand for your beta blocker. Which kind of beta blocker? That is your non-selective beta blocker. Cardio selective तो दे सकते हैं, बट नॉन सेलेक्टिव बीटा ब्लॉकर शुड बी अवॉइडेड, राइट? सो एटलीस्ट इतना याद रखिएगा, आपका काम निकल जाएगा. अवॉइड डीएनबी इन द प्रेगनेंसी, बट लेडी हार्डिंग मेडिकल कॉलेज विल बी गिवन इन द प्रेगनेंसी. ओके, एक बार फिर से देख लेते हैं द क्वेश्चन वंस अगेन. सो पॉसिबल, राइट, पॉसिबल साइड इफेक्ट. नाउ आउट ऑफ ऑल ऑफ देम द क्वेश्चन, लेट अस टॉक अबाउट द क्वेश्चन. एक्चुअली the question that we are having, the correct answer here is your alpha methyl dopa, because it is the alpha methyl dopa that happens to be, it is the alpha methyl dopa that happens to be an alpha 2 agonist, right? It happens to be one of the alpha 2 agonist. Okay, the side effect, whenever you look at the alpha 2 agonist, the most common side effect overall is considered as a sedation. Apart from that, guys, it will also be associated with the other side effect, like for example, it can cause extrapyramidal symptoms, right? Extrapyramidal symptoms, yes, they are presynaptic. So अगर ये है, समझ लीजिए, presynaptic adrenergic neuron, this is the alpha 2 receptor. So whenever you are trying to stimulate alpha 2, right, they will be actually causing inhibition of the noradrenaline release, right? They reduces the noradrenaline release, and oftentimes they are noradrenaline, right? The precursor of the noradrenaline is dopamine. So oftentimes dopamine will also be reduced. If dopamine will be reduced, definitely it will be end up causing your extrapyramidal symptom as well, right? Extrapyramidal symptoms, right? And also it can cause your lactation, right? Also it can cause your lactation because decreased amount of dopamine, right? Always and always remember, dopamine is having inhibitory role over prolactin. ये तो सबको पता है ना? Dopamine is having inhibitory role over prolactin, right? So if dopamine is gone, this prolactin control is also gone. So the patient will be having hyperprolactinemia. Okay, so this hyperprolactinemia in the female can present with the galactorrhea, in the male can present with the gynecomastia. Another MCQ, female में hyperprolactinemia, right, galactorrhea and infertility के साथ present होगा, and male में it will be causing gynecomastia. Okay, apart from that, it will also be causing development of the certain nightmares. This has also been, right, reported. Nightmares has also been reported. Okay, hepatotoxicity. Apart from that, another thing that is reported is that this alpha methyl dopa, it can cause your Coombs positive test, right? It can even cause your Coombs positive test, an antihypertensive drug that can cause your Coombs positive, because it will be causing your development of the autoimmune hemolytic anemia, right? They actually cause your autoimmune, they can cause development of the autoimmune hemolytic anemia. And any autoimmune hemolytic anemia, I am sure in your pathology you must have read, it will be end up causing your Coombs positive test. So antihypertensive causing Coombs positive, that is very, very important, right? So that is your alpha methyl dopa. Okay, remember this. So in around 5% of the patient, those who are receiving alpha methyl dopa, they have usually reported that they can cause development of the Coombs positive. So two question I told you, Coombs positive, alpha methyl dopa again, right? And the side effect that has been mentioned here, एक बार मैं फिर से इसको underline कर रहा हूँ, right? Nightmares, vertigo, reduced concentration, sedation, right? This is all the side or extrapyramidal symptom, they are all associated with the alpha methyl dopa. Apart from that, remember, valsartan is the contraindicated. No, ये तो मैंने बता ही दिया था पहले ही, right? Valsartan is the contraindicated. नहीं, pregnancy में BP is controlled. BP is controlled because why? What is the relation with the pregnancy is that which of the following will you give in pregnancy? So valsartan तो हो नहीं सकता ना. Valsartan हो नहीं सकता because valsartan is the contraindicated. That is the relation. That which of the following will you give in pregnancy? Verapamil likewise, verapamil भी नहीं देंगे, ये भी contraindicated है because DSP will be given, है ना? Beta blocker like oxycodone can be given, right? Because right beta blocker like cardioselective beta blocker will be given. Okay, cardioselective beta blocker will be given. So pregnancy के साथ relation यही है कि which of the following can be given in pregnancy. That's all. ठीक है, clear है? Can I proceed further? Safer in pregnancy, Lady Harding Medical College. Avoided in pregnancy, avoid DNP. Okay.